Good afternoon, everyone. I'm going to ask for some response so I can make sure you're listening. Good afternoon, everyone. All right. Are you ready to get going? All righty. Today, our session post-lunch, so we'll try to keep you awake, is the coalition-led efforts to improve health equity, the role of the National Professional Medical Societies. In your program, it's listed a little bit differently about the role of medical societies in eliminating disparities, but we're talking about a nuanced approach in the coalition-led efforts of medical societies. So medical societies actually joining forces toward elimination of healthcare disparities. Thank you for joining us, and special thanks first to Dr. Puckerin and to Bill Griffith and to the NMQF for having us here. I am Dr. Christopher Hollliday, Director of Population Health in the Improving Health Outcomes focus area of the American Medical Association. It is my pleasure today to moderate this important and timely discussion. Professional medical societies have a large and important presence in the U.S. There are more than 100 of them, most with affiliates at the state and local level, which considerably multiplies that number. Imagine with me, if you will, if all of these medical societies joined forces around a single, prevailing, and critical issue, reducing healthcare disparities. Well, many medical and allied health societies have done just that by joining the Commission to End Healthcare Disparities. As you'll hear from our panelists today, the Commission to End Healthcare Disparities generates tools that its member societies can leverage and spread, and conversely raises awareness of best practices developed by its member societies to unify efforts to achieve quality care for all. Today, our panelists will help illustrate how that work is taking place and will present opportunities for you to join in and help shape that important work. I could easily spend the entire session just simply talking about these distinguished panelists and their many accolades, but you've got their full bios in your packet, so I'll just take a little bit of time to just give some information about them. Our first speaker will be Dr. Jeremy Lazarus, whom many of you already know. Dr. Lazarus is co-chair of the Commission to End Healthcare Disparities and is also the immediate past president of the American Medical Association. Dr. Lazarus is a board-certified practicing psychiatrist who is intimately familiar with the existing and potential power and role of the medical society. Along with his leadership at the Commission and at the AMA, Dr. Lazarus is a past president of the Colorado Medical Society, the Colorado Psychiatric Society, and the Arapahoe County Medical Society, and he is a distinguished fellow and past speaker of the Assembly of the American Psychiatric Association. Today, Dr. Lazarus will speak about the creation, evolution, and unique relevance of the Commission to End Healthcare Disparities. Let's give him a hand. Immediately following Dr. Lazarus, we'll hear from Dr. Elena Rios. Dr. Rios serves as president and CEO of the National Hispanic Medical Association, which represents Hispanic physicians throughout the United States. Dr. Rios also serves as president and NHMA's National Hispanic Health Foundation, and in addition, she holds leadership roles for organizations such as the National Hispanic Leadership Agenda, Campaign Against Obesity, the GE Healthcare Developing Health Access Advisory Board, and the U.S. Office of Personnel Management Hispanic Hiring Task Force. Today, Dr. Rios will talk about how the NHMA is leveraging provisions in the Affordable Care Act to advance its mission to improve the health of Hispanics and to advance the Commission's mission of reducing healthcare disparities. Let's give her a hand. Finally, we'll hear from Dr. Omar Hasan, Vice President in the Improving Health Outcomes focus area, which we call IHO, of the American Medical Association. Dr. Hasan leads a transdisciplinary team, of which I'm a proud member, that is developing and implementing the AMA's national strategy for improving health outcomes and curbing cost growth. IHO's work is focused on two high-impact medical conditions, diabetes and cardiovascular disease. Prior to this role, Dr. Hasan spent more than a decade practicing general internal medicine and leading quality improvement and patient safety initiatives across diverse healthcare settings. Today, he will talk about how the AMA is helping the Commission to End Healthcare Disparities put its strategic plan into action on the front lines of care, activating a critical component of reducing disparities in the ambulatory care setting. And let's give him a hand as well. After our panelists' presentations, we'll open the floor for Q&A, which I hope will be a robust opportunity for us to react to what we've heard and give input on how we can share our opinions on how to best address healthcare disparities with these wonderful organizations. And I'll turn it now over to Dr. Lazarus.
Well, thanks, Chris. Let's see, do I need to push this? Oh, there we go. Good afternoon, everyone. Great to be with you again this year. I think this is my third year here, and I learn something new every time I come here. You'll be hearing many of the same themes in what I'm going to be talking about as you've heard during lunch. But I'm very happy to be here to talk about America's physicians, the fight against disparities, and joining hands with other professional medical societies and many others on initiatives to promote health equity and eliminating healthcare disparities. With our partners in the Commission to End Healthcare Disparities, the National Medical Association, the National Hispanic Medical Association, the National Minority Equality Forum, and many others. At the AMA, we seek to end inequality of care rooted in race or ethnicity, and we've made it a priority of our association. In fact, the AMA has been a member of the Commission to End Healthcare Disparities since its inception in 2004. And it was an aggressive response to the Institute of Medicine's groundbreaking report, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. So what is the Commission to End Healthcare Disparities? We've made it our goal to work closely with other groups. Today we have more than 70 member organizations. We educate physicians and allied health professionals about disparities. We promote racial and ethnic diversity in the health professions, including key leadership positions across the healthcare system. We advocate to improve health outcomes for minority population, and we seek to improve the quality and availability of research and data necessary to end healthcare disparities. Now, I want to give a particular shout out to the Congressional Black Caucus Health Braintrust, which is on the front lines of assessing the repercussions of policy proposals on minority health and supporting legislation that will ensure health equity. And of course, a special thanks to U.S. Representative Donna Christensen. You all know her very well. We're very proud of her. And she is the only sitting African-American physician in the House. And for her fights along these lines, we awarded her our highest honor in 2011, our top government service award for an elected official. I was proud to see her achieve that. We also wish her well in her upcoming fight, and hope you do well, Representative Christensen. Now, at the Commission, we're pursuing the goal of ending healthcare disparities at a fundamental level. And that principle drove our support as a Commission and our support at the AMA for the Affordable Care Act. Now, we acknowledge that the ACA isn't perfect, but it was a long overdue change. We don't agree with all of it, but there's so many parts of it that do well for physicians, and especially towards ending disparities in healthcare. It includes many provisions that will end disparities in healthcare. It increases the number of minority and disadvantaged students enrolling in healthcare training programs by lowering financial barriers. It provides grants to medical teaching facilities that have a record of training those from disadvantaged or underrepresented backgrounds, that serve minority or underserved populations, and provide cultural competency and health literacy training. The ACA improves preventive care and care coordination, increases funding for community health centers. It expands the reach of Medicaid, ensuring health coverage for millions of previously uninsured Americans. All in all, there are more than 60 provisions in the ACA that contribute directly or indirectly towards ending disparities. Now, as all of you are aware, many chronic diseases that impact longevity and well-being, such as diabetes and hypertension, are more prevalent in African American, Hispanic, and Native American communities. I don't expect you to read everything on this slide, just to tell you that the orange bars are minorities, and for the most part, they're much worse than the blue bars, which are Caucasian. We also know that there are significant differences in the management of these chronic conditions, resulting in unfavorable outcomes among minority populations. So, for instance, African American, Hispanic, and Native American communities suffer rates of diabetes or diabetic complications that are 50 to 100% greater than the general population. And in some states, hypertension prevalence is up to 10% higher among African Americans, Hispanics, whereas control rates are as much as 10% lower compared with whites, leading to significantly more strokes and worse functional outcomes for stroke victims. Now, it's these types of highly prevalent chronic medical conditions and the glaring disparities in care and outcomes for such conditions that are the key drivers of health disparities in our nation. So improving outcomes for these complex conditions will require a combination of strategies from clinical care redesign to public health advocacy to greater cooperation between clinical care teams, patients and families, and the community. And the Commission, our Commission to End Healthcare Disparities, is in a unique position to make a significant favorable impact on health outcomes for these conditions. Through the Commission, the AMA, NMA, and NHMA have joined forces and are working collaboratively with several other organizations to eliminate disparities in health and health care. Now, we're doing this using hard science. As you heard Gary before, we need to have the science here, we need to have the facts. In 2005, the Commission conducted a national survey of physicians' experiences in providing care to patients from racial and ethnic minorities. That survey sampled 1,700 physicians across the country with a response rate of 52%. And it found that over half of physicians agreed that minority patients generally receive lower quality care than white patients. And almost 2/3, or 62% of physicians, reported witnessing a patient receive poor quality health care because of the patient's race or ethnicity. A follow-up study that was done in 2008 found that most physicians who expressed interest in improving care for minority patients and were aware of and believed in the effectiveness of strategies to reduce disparities did not regularly use such strategies in practice. So we need to put that information to work to make a tangible impact on reducing health disparities. And that work begins with acknowledging that those gaps exist and working together to fill those gaps. So the Commission provides a multidisciplinary forum within organized medicine to discuss evidence-based approaches to improving health equity. What are some of the Commission's accomplishments to date? In the decade since its founding, the Commission has made several strides towards understanding and reducing healthcare disparities. First, we've brought together this national coalition of organizations that span medical professional societies, state medical societies, allied health professionals, and the American Association. So we've opened up a dialogue on health disparities to a very broad and diverse audience. And this growing strength in numbers has allowed this Commission to become a strong advocate for reducing healthcare disparities, such as approaching states' offices of minority health with a petition to improve race and ethnicity data collection and reporting by hospitals and health systems, and also by advocating at the federal level to extend Medicare coverage to include community-based diabetes prevention programs and take steps to increase program availability in underserved communities. And you'll hear a little more about that from Dr. Rios. Now, the Commission has also published recommendations to guide clinicians in their efforts to address healthcare disparities. We had a white paper on collecting and using race, ethnicity, and language data in ambulatory settings, and also a white paper on promoting appropriate use of physicians' non-English language skills in clinical care. The Commission also developed a toolkit to educate health professionals and the general public about health disparities and published on the subject of health disparities in peer-reviewed medical journals. We're also working hard to attract minority students to careers in health and medicine, including conducting our Doctors Back to School program and mock medical school interviews at Commission meetings twice a year. Now, building on our decade of success, members of the Commission engaged in a strategic planning process a month ago or so, And after deliberation, our steering committee agreed on a 3-year plan emphasizing greater focus and a 3-pronged approach to addressing healthcare disparities and workforce diversity. Now, I won't go through all of the plan with you, but the 3 salient elements of the plan are: first, by reducing racial and ethnic disparities in prevention, control, and outcomes for a select group of high-impact medical conditions, starting with hypertension and type 2 diabetes. Second, by promoting diversity in the healthcare workforce and leadership development opportunities for underrepresented minorities. And third, by improving race, ethnicity, preferred language, LGBT status, disability status, and zip code data collection, and promoting stratification of quality reports by these variables and focusing local quality improvement efforts on reducing disparities. As you heard before, we need to have that information so we can identify those areas where we need to improve in terms of quality and outcome. Now, before I finish, I just wanted to provide an invitation to all of you who do not happen to be members of the Commission to come and join forces with us. We can tell you a lot more about the Commission, but we welcome your interest and would hope that you would consider our Commission. Now, I'm going to now turn it over to Dr. Elena Rios to tell us about the National Hispanic Medical Association's contributions to addressing healthcare disparities as a member of our Commission Secretariat. Elena?
Thank you.
Thank you.
Thanks. Let's see. Next. I did. Oh, wait a minute. Okay. So I was going to focus my comments on healthcare disparities and workforce. So the Affordable Care Act, we know, is going to have a lot of demand for workforce for our communities. And overall, the key trends, and you can probably read this easier than I can. It's kind of far from me. But basically, we all know by 2042, our country is going to be a new emerging group of people that are no longer going to be minorities. And let's see what we all call ourselves. But it's a very, very positive outcome in the next 20 years, and we need to start preparing for that outcome. We have, for the last decades, been trying our best to have affirmative action maintained in our society, despite the Supreme Court decision this week. But we all know there's a lot more that needs to be done, especially for students in grammar school and middle school to become doctors and nurses and public health professionals. But our nation is undergoing major transformation. This is a very positive thing, and it's not just the Affordable Care Act, but I think there's really been a need to, and with the leadership of the Congressional Black Caucus and the Congressional Tri-Caucus, we've really seen the ways of the future already being shaped. Cultural competence is now a requirement in some states. And the class standards were actually improved upon by the Office of Minority Health over this last few years. So we see the important changes happening in our healthcare system because of the demand of the changing demographics. In terms of advocacy, we can talk about all the advocacy that the Commission's been working on. And as was mentioned, many of that advocacy is focused on diseases like diabetes, heart disease, cancer, HIV/AIDS, hepatitis C, asthma, lupus. But there's also social determinants that we have to look at: poverty, crime, the low levels of education, nutrition, not having safe parks, and of course, chronic stress in our communities is really the driver behind so much chronic illness. We have supported the Affordable Care Act and seen the increase in access to care through affordable insurance, quality care models, payments, primary care focus, coordinated care, and of course the Office of Minority Health structure being improved upon across all the agencies at HHS. And especially the race, ethnic, language data was another major support by the Commission. Recently we had a congressional briefing. NHMA's done congressional briefings for about 5 or 6 years, and this was the first time that we actually co-sponsored with the Commission. It was great. Again, with the Tri-Caucus, and we did have Congresswoman Donna Christensen there and Congresswoman Lucille Roy Ball and Congressman Raul Ruiz. And we talked about the innovations that need to be looked at within health disparities. So I'm going to just talk a little about what I spoke about at that briefing. Well, first, let me just give a plug to Dr. Lazarus. The Medicare Diabetes Prevention Act was his major focus. And again, it is very important to realize how many minorities have diabetes. And within Medicare, it's important to see the improvements that can be made in our laws to be better able, for professionals to be able to better care for our patients, and especially when it comes to prevention and prevention education. But I focused on the healthcare workforce, and as I mentioned earlier, the Affordable Care Act now has more and more people that are insured. Well, now we need more and more people to take care of the insured people, especially in our communities, who are going to still remain part of the safety net. They're going to be going to clinics and private doctors and private dentist offices. Not everybody's going to go into major healthcare systems. I mean, we would like to see the ACOs created and all the patient-centered medical homes, but we're still going to have to rely on our community doctors in our communities. So state and local government flexibility and resources are going to be needed to develop the health workforce innovations and recruitment strategies. And there will be a drive for the transformation to a patient-centered care model that promotes access, coordination across the continuum, wellness, and prevention by collaborating with physicians, starting with primary care in ways that allow them to successfully manage the health of their patients and thrive in a value-based reimbursement environment. And this, important enough, and if you can't read the bottom, this is from the White House website talking about the Affordable Care Act. So there is a focus on the importance of workforce. Investment in primary care is probably the biggest focus, to have grant programs that support the training of primary care providers, all of the different providers, and payment bonuses to primary care doctors. Geographic distribution needs to be looked at, and telemedicine, especially for rural care and others. But one of the things that I found interesting, and this was over the last couple of years at our National Hispanic Medical Association conferences, as the money from the federal government has been downsizing because of sequestration and because of budget cuts, one of the programs that's been cut are our recruitment programs. So we started meeting with the White House on how we could maybe look have a different approach. So we were told to look at the STEM programs, and we met with the historically black colleges and the Hispanic serving institutions STEM programs that are within the Department of Education. The ACA actually supports the development and implementation of health sciences programs in public secondary schools, and this is through the Department of Education, so that students can prepare for careers in health professions. So the President Obama, in one of his legacies is going to be this whole focus on STEM. There is a Council of Advisors on Science and Technology report. I would ask you to go to that report to see all the recommendations that they made. But his initiative, which was started in November 2009, after he took office, the President launched the Educate to Innovate initiative to move American students from the middle to the top of the pack in science and math achievement over the next decade. And to date, this nationwide effort has garnered over $700 million in public-private partnerships and hit major milestones in the following priority areas: building a CEO-led coalition. These are from companies, the private sector, to leverage unique capacities of Change the Equation is the name of their campaign, and showcasing and bolstering federal investment in STEM, and actually looking at the STEM programs across many, many different agencies. And we all know in government that there are so many silos, so many times there's replication of activities. So let me just fast forward to this year, and in fiscal year 2015, President Obama's budget does include STEM, and these are some of the activities, some of the major activities that are being proposed. A teacher core program to have more teachers of math and science, a STEM innovation network to actually have post-secondary education and careers in STEM, and with an innovative network of groups coming together, not just the school districts or not just the community colleges, not just the medical schools, but all coming together. I'm not going to go over these specifics, but we had a diversity summit. We called it the President's STEM Initiative and Increasing Diversity in the Health Professions, and we just thought that we needed to look at diversity in health professions in the President's STEM Initiative, The recruitment, the counseling, and the education still needed. We included speakers from the White House, the Department of Education, both the Black and the Hispanic STEM programs. The National Science Foundation also has a Black and Hispanic STEM program. NIH, HRSA, Congress, the Institute of Medicine, the AAAS, the New York Academy of Medicine, Robert Wood Johnson Foundation. And we had 25 African American and Hispanic medical education leaders, because it's in medical schools that we have had the history of medical school recruitment of our minority populations. Anyway, we had 3 recommendational working groups, and these were the recommendations. The major recommendations, overarching, were to increase awareness that medicine is a STEM discipline. And in fact, we're now looking at STEM as STEM squared, so science, technology, engineering, math, and medicine. We're developing the recommendations were to develop evidence-based and metrics to share best practices, develop the business model, have stakeholder input to the Office of Management and Budget, which is the White House, and Congress, with NHMA's continuing efforts to get this report out, and to work with all our congressional colleagues. The recommendations from the work group from K through 12 were to engage parents and communities about math and science, and to provide teachers with training and tools, and have more effective counseling and mentoring, and increasing the pool of students, of course, would happen if we could do that, and increasing informal STEM learning, service learning, having STEM in museums and libraries, and not just in the school curriculum, and targeting funds for diversity STEM programs at HBCUs and HSIs, and really to focus on those institutions and start a whole new ground-up approach instead of the medical schools top-down. We need to do both, and the AAMC does a great job, and the medical schools do excellent jobs in recruiting students, but we just think that there should be a focus on our Hispanic serving institutions and historically Black colleges, because they already have STEM programs. The recommendation for the pre-med level, those students coming out of the colleges going into medical school, would be, again, to advise on career options beyond medicine. Not everybody can get to be get into medical school, we realize that. Encourage science with new learning styles. The MCAT, of course, the test taking is very important. Institutions need to adapt best practices. Changing the admissions perception of 2-year institutions. And that's from the medical school admissions committee perspective, that 2-year institutions is a reality in our communities, especially with the high cost of higher education. And students, some students just are transfer students. Link biomedical science and health professions with programs in the college level, and also increase collaboration again with the post-bac programs and have them become master's programs, because it turns out that the Department of Education can actually fund post-bac programs if they actually give a master's degree. So the last set of recommendations was about having public-private partnerships. And again, we recognize that we have to expand federal authority for this to happen. There needs to be many, many more opportunities for industry, as was mentioned earlier today about clinical trials, but industry and hospitals and other corporate sector leaders in our communities need to work together with our institutions to help with science and math. Engage the technology sector, develop regional and local alliances, and then there's even tax incentives that have been used in California, and increasing internship programs with companies came up to the top, bubbled up to the top as a major recommendation. And there was a need for an advocacy campaign really to Congress about STEM and health careers. So, and just closing, who are we? We basically, NHMA started in 1994, and we did join the commission at the very beginning and have been very instrumental in building our databases to find more and more Hispanic doctors. We developed a foundation to develop a scholarship program. We serve as a resource. We support Hispanic physician leadership, and we provide networking opportunities at our national conferences. These are some of the programs we do, and we're very much interested in nominating leaders and getting them involved at the table, whether it's in the private sector or the public sector, through our leadership training programs. And we do have a network now that includes not only medical societies, but a health professional leadership network working closely with our Hispanic nurses and dentists and health professionals et cetera. And we're very much interested in the next generation with the Latino Medical Student Association and our partners in contact. So I'll just stop there. And Omar is going to continue on with the Commission's work. Thank you.
Thank you very much for the opportunity to present today. So I think somebody's going to try and help load the slides, but while that is happening. Oh. Okay, so we can do without the slides. I'm going to talk through what I was going to show on the slides. But before I do that, I really wanted to invite folks who are attending today to go on the Commission website if they'd like to find out more about the strategic plan. A lot of thought has gone into developing this new strategic plan, which has, as you saw, 3 focus areas. And you can learn a lot more about the rationale behind these choices and what we'd like to do in each of these individual areas by visiting the Commission website. It can be accessed through the AMA website and through some of the other member organizations as well. When Dr. Lazarus was giving his talk, he showed a slide where the Commission had conducted surveys over the years, starting in 2005, of why physicians are experiencing difficulty in addressing healthcare disparities in practice. And parts of those survey studies consisted of focus groups where physicians were asked what it would take to help them overcome the obstacles to reducing healthcare disparities in clinical care delivery. And one of the key obstacles that was expressed was the absence of reliable information on healthcare disparities in terms of performance measures at the practice level. So I'll talk a little bit about the plans, the Commission's current efforts and future plans to improve race, ethnicity, and preferred language data collection and reporting, and more importantly, the use of these data to understand and begin to address healthcare disparities in ambulatory clinical practices. One might ask, why should we start with the ambulatory setting? And the reason is that that's where most of the patients receive care for chronic medical conditions, such as hypertension and diabetes, and the Commission had agreed to focus on these conditions, at least to start out before going on to other conditions to address healthcare disparities. So based on the Commission's strategic plan, staff at the AMA, led by Dr. Hollliday and his team, approached the Chicago Regional Health Information Technology Extension Center, or CHITREC, with a proposal to partner on a pilot project. And we chose Chicago for the very important reason that the AMA headquarters are there and they're easier to work with in our neighborhood. Now we also, that was a joke, but we also sought to partner with them. Well, because of their expertise with EHR systems and because they are currently assisting scores of practices in the Chicago area with meeting the standards for meaningful use stage 2. And we could not find another partner who had the capacity, the resources, and the expertise to get into physicians' offices, have very good knowledge of their electronic health record systems, and was willing to work with us on this important subject. The aims of this pilot effort, which will unfold in the next year, are to develop and pilot test a toolkit to assist ambulatory clinical practices with improving the accuracy and reliability of race, ethnicity, and preferred language data collection and reporting, to demonstrate the use of this toolkit to stratify and interpret clinical performance by race, ethnicity, and preferred language for at least one PQRS measure. We envision the toolkit to consist of best practice recommendations for gathering, recording, and interpreting race, ethnicity, and preferred language data, all designed to integrate into the ambulatory workflow. As pre-work for this pilot, we are reviewing existing guidelines for categorizing race, ethnicity, and preferred language. We are also reviewing published experience on such data collection and reporting. To start off, we will harvest best practices and lessons learned from 2 to 3 high-performing ambulatory clinical practices that have improved the accuracy and reliability of such data collection. We have developed a survey instrument for this purpose, and it's currently under review by content experts in the Commission. Input from these high-performing ambulatory practices will help inform the creation of the toolkit. We will also build upon an existing toolkit developed by the Health Research and Educational Trust of the American Hospital Association, as well as some other existing toolkits that we have reviewed. This draft toolkit will then be piloted and refined by working with 3 ambulatory clinical practices who will use the toolkit to improve the reliability of such data collection and reporting and interpretation, and then coming up with plans to address disparities for a specific clinical condition. Content experts and clinical leaders from the Commission member organizations are participating by providing their input in compiling and refining the toolkit, and also they will help us disseminate its final version through their membership. If needed, the Commission will also advocate for support from EHR vendors in implementing the toolkit in ambulatory EHRs, and we are relying on the expertise from the Chicago Regional Health Information Technology Extension Center, CHITREC, to guide us in whether we need to approach EHR vendors and how we should go about doing that. We expect to have interesting results from this pilot to share with you next year at the summit. In the meantime, I welcome your reactions to what I've presented here today, along with my other fellow speakers and panelists. Thank you.
Thank you to Drs. Lazarus, Rios, and Hasan. This is an opportunity now for you to ask questions and for us to engage in a dialogue about the great work that we're here that's going on with the Commission to End Healthcare Disparities along with these respective organizations. And we have Dr. Lubin Johnson.
Thank you, Dr. Hollliday, and thank you to the presenters. So I am Vice Chair of the Minority Affairs Section, Governing Council of the American Medical Association, also longtime member and past leader of the National Medical Association. I know that the last presentation by Dr. Hasan was more related to the third goal, I guess, of the Commission. And I'm sharing some things because I appreciate the work that's been done thus far with the Commission. I know that there are a long ways to go, and I'm glad there are some goals set up. But I guess my heart is kind of heavy because I'm from Chicago. And I grew up and I live half a mile from one of the physicians who filed a lawsuit in the 1960s to get hospital admission privileges in Chicago. And part of that was because, a big part of that is because the preponderance of African American physicians couldn't join AMA until the 1950s, 1960s. And actually the Commission came about after AMA appropriately gave a formal apology to NMA at 2008 convention in Atlanta, Georgia. So I'm sharing this because I'm not sure if everyone here is aware of that history. Heart is especially heavy because I flew here from Chicago yesterday, Oak Brook, Illinois, Illinois State Medical Society Convention, where former Minority Affairs Consortium Chair William McDade became the first African American president of the Illinois State Medical Society in its 174-year history. Wow. And it's going to take a lot of things to help decrease disparities. And I prefer the words promote health and produce health equity. The Commission, some of the IHO initiatives, Doctors Back to School, because as a favorite retired judge who's now deceased, that Celine knows and Luana knows, used to say you can't be what you don't see. Right. And Doctors Back to School does that. The pre-med interviews, all those things and more are needed if we're going to be successful in producing health equity. Thank you.
We have another comment. Does anyone want to react to Dr. Lubin Johnson's comments, or
I'd just like to say thank you for those comments and thank you for giving that history, which is a shameful history of the AMA. But I think we have gone far. I also grew up in Chicago on the north side. But I'm also very proud that one of the recipients of the AMA's Foundation National Minority Scholars Award, Dr. Taman Osborne Roberts, is the first African American president of the Colorado Medical Society this year. So we've come a long way.
Comment or question?
Yeah, comment and question.
If you could say your name as well, please.
I'm Dr. Bernal DeWitty. I am with the American Association of Colleges of Nursing, located here in Washington, DuPont Circle. I serve as a program director for the Robert Wood Johnson Foundation New Careers in Nursing Scholarship Program. I appreciate what you offer this afternoon in terms of reducing healthcare disparities and promoting equality of health care. And as I listen at your comments about the coalition, the question that arises for me is, in this day where we focus so heavily on interprofessional collaboration, I hear no conversation about how other healthcare providers are welcome to this party. Nurses represent the largest component of healthcare providers. And as we work towards these major initiatives to improve the healthcare of all Americans, my question to you is, have you not considered interprofessional collaboration or inviting other parties to the party?
We'd welcome your participation. Just give us a call, submit an application, and we'll certainly consider your being in that. We do have the American Podiatric Medical Association as members. We have other allied health professions as members, including a physician's assistant, a national organization. So we'd welcome your participation.
We will certainly follow up on that, and I'm wondering if there's another way to make that invitation more widely known so that other parties who might be interested can do just that.
Point well taken. And just in response to that, I don't know if Dr. Hasan wants to respond, but we are also going to be being a little bit more strategic going forward with the Commission in Healthcare Disparities and being more proactive in recruiting. So your point is well taken, and that's part of our strategy going forward. So thank you.
My name is Alice Coombs, and I'm one of the original members of the commission, and we actually have the Black Nurses Association, Hispanic Nurses Association have been represented long-term. We have physician assistants, we have podiatry, we have probably every profession, state medical societies that are on the commission. And so just so you know, that has always been an incorporation and a goal and objective is to be multidisciplinary. And we started off, I guess about 3 years ago, we actually had an interprofessional team concentration at one of our commission meetings. So just so you know, we've always kind of had that, but there is a process if your organization would like to be represented at the commission. And so I just want you to know that we actually incorporated other disciplines within the commission.
Thank you, Dr. Coombs. Next question or comment? Dr. Tran?
Yeah. Thank you very much for my name. I'm Ho Tran. I'm the president and CEO of the National Council of Asian Pacific Islander Physicians. And I very much appreciate the presentation of Dr. Lazarus and my dear friend Elena, Rios, and Omar. But my point is that for us, you know, that there's not much, not much mention of the Asian population having disparities at the same time. So first, you know, that we are also a member of the Commission to End Healthcare Disparities, and that we have been also very much working closely with the AMA CHDD. The point is that, you know, even though that we are not mentioned, but we are we are lumped together, and we do have issues of disparities within our population. At the same time, even though that we do have a high percentage of the medical workforce from Asian physicians, but when you disaggregate the data, we do have, you know, within our subpopulation very much, you know, at the difference disparities. For example, for the Native Hawaiians and Pacific Islanders, we are lumped with them as well. Is less than 1%. For certain Southeast Asian physicians, we are also very much at a 1 to 2%. So very much would like to very much to be included in the Disparities movement, but at the same time, to be working together and share the commonalities, and the best practices at the same time. Thank you.
Thank you.
Well, Omar might want to say a little more about this, but your organization was well represented when we made our strategic plan, and if you look in terms of the granularity, it includes in many of the sections of it the very issues that you're talking about, because we were aware of that. It's in our strategic. I couldn't go through the whole thing, but please take a look at the plan. It's got all of those aspects in it.
Next comment or question? If you could say your name and your organization.
My name is Dr. Barbara Hatcher, and I'm a professor of nursing at George Mason University. And it's just a general comment, and I don't know how to say it in a diplomatic way, but to me, when you talk about reducing disparities, it has to be patient-focused. I really do not think the ACA is about what is good for physicians, nurses, or any other health professional. It is what's good for patients and what we must do to improve the health status of all Americans. And I heard what's good for physicians. I want to know what's good for patients.
Thank you for your comment. If I can just follow up with that, I have an actual question I wanted to pose to the group myself, and it has to do with what is the role of patients in reducing healthcare disparities. So thank you for reminding me of that. And as part of that role, how do we first begin to engage patients as part of healthcare disparities? And so we can come to that answers to those questions after your question and comment.
Sure. I really would like to get some comments. Salim Al-Nurdan, I'm sorry. From Chicago. It looks like we got a lot of Chicago around up in here. Well represented. Maybe they got something to do with the president. Before then, we might not want to tell everybody. Anyway, I really want to challenge you as Gary does. He likes to challenge, and this is it. This is the part that always gets me. I come to D.C. to find out what's going on every year. Now I'm pretty active in the community. The community don't know what y'all talking about. So when I hear, and I guess I'll comment it again, when we start talking about community engagement, community involvement, community whatever words that the new scholar people saying the word ought to be, it's not getting down to the hood. And I really would like to again say that we'll probably do the most conversation about community at the end of the program. And that's not something that I think people do through conspiracy. I think we just do it through force of habit. We'd like to challenge you as well as offer you an opportunity. We at the community level would like to participate in helping you and you helping us get more information about what it is that's going on at the community level, at the local schools, at the whole thing that's going on. But I really applaud you for all the things that you're doing, but I'd love to hear any thoughts that you may have or anybody who you may be working with who we can contact to follow up with in terms of making sure that that message in community. See, we think community means from the community up. And it doesn't make any sense whether it's the government, the industry, or us good doers. We still got to come from the community first. Thank you.
Thank you.
Thank you to all Chicagoans. Thank you to all Chicagoans that are here. I'd first like to briefly answer the first question because I think, we all hear things and filter. What I said was the ACA was important for physicians, but I then read a list of about 20 different things that are important for patients. The reason the AMA supported the Affordable Care Act was not because it was good for physicians, but because it was good for the American public. We thought it was the right thing to do, something that was long overdue, over 100 years, and it wasn't because of how it was good for physicians. There were a couple of things in there that were okay for physicians. It was mostly for patients. So I hope that answers your question. That's truly how, and I went through that whole process with the AMA. What we're trying to do is to try to have interventions that help Medicare diabetes is help provide benefits for Medicare patients, for evidence-based interventions, for so for prediabetes, so the patients don't go on to develop diabetes. Once we get something like that, we need to work with communities to spread the word about what evidence-based interventions, not just talking about things, but things that really work that make people better, not just talking about those things. So the degree that you can help us as community activists, those of you who are, to spread that word, but it has to be about things that work to actually get people better. I asked our moderator to ask me a question. If you don't mind, I'll sort of morph into that. Yeah. You know, we do spend a lot of time talking about interventions that help with the downstream aspects of medical care. When people actually have diabetes, or they have hypertension, they have cardiovascular disease, we have to get upstream from that. We have to get into the communities, help people have better diets, you know, exercise, try to eliminate poverty, all the upstream issues so that they don't develop the terrible illnesses that afflict a lot of Americans and especially minority populations. So I think we do need to, in a public health way, work with the communities to do that. But I think we have to provide information to the communities that will be helpful and evidence-based.
Yeah, and I just wanted to, I'll just add to that comment about being part of the communities and talking with the community. I think that's what we're all here for. The opportunities that our organized medicine colleagues have within the commission is to understand some of the most basic issues within our minority communities that many doctors don't recognize until they serve the patients from those communities. Unlike many of the minority organizations, the NMA, the NHMA, the Black nurses, the Hispanic nurses, and some of the other minority organizations that are part of the commission, we primarily represent people who come from these communities. So we've been the first in our families to go to college. Our parents are working class parents. I mean, not all. I'm not going to be stereotypical here, but I mean, some of our Latino and African American colleagues do come from families that have made it in the second, third generation and are in professional households. But the majority of us aren't. And we recognize the importance of coming together and learning from each other so that we can voice the opinions of the group and be more educated. And out of diversity comes more of an educated leadership to be able to tell our colleagues in Congress, for example, with the congressional hearing that we did, or in our community organizations, or with the greater AMA or the greater NMA, the greater, all the different organizations that come to the table, they're just representatives of larger tables, and we all need to start thinking about how to make the commission's work actually move to the community. And that's really what the commission's all about, is exchanging information and being more culturally aware and respectful of all of our issues. And you know, the social determinants are the things that are going to matter, and we do have to figure out a way through health policies and other policies to include more disparity targeted interventions, as Dr. Lazarus mentioned.
So we've received our 5-minute warning, and we have actually less than 5 minutes. And so I'm going to ask, as they do in many faith-based traditions, no more stand, and ask these last two folks to have comments or questions for the panel, and then we're going to wrap up.
Hi, I'm Jamila Rashid, Executive Director of the Urban Health Program and former federal employee of the Office of Minority Health, where I led several initiatives in which we work to really, from the grassroots, incorporate patient involvement and patient engagement, really building on the comparative effectiveness research. And to speak to what Celine was trying to indicate is the need from the grassroots level to engage patients, not after you've figured out what you want to do or need to do, or prepared your materials to educate the community, but bring them to the table at the very beginning. In the last initiative that I worked on in the Office of Minority Health, that's what we sought to do, was when we had our first meeting, we had patients at that meeting, and we continue to engage them along the way. And when you do that, you get the buy-in, and you educate the patients till they become almost as knowledgeable and vocal as you are about what you're trying to do. And I think that is the message he was trying to deliver.
And our final comment.
Thank you. My name is Mary O'Connor. I co-chair the Movement is Life Caucus, and I wanted to respond to the comment from the gentleman from Chicago. We ran 2 pilot community-based interventions, one for African American women and one for Hispanic women. Our space is healthcare disparities relative to arthritis and musculoskeletal health, which is basically impacts all these medical comorbidities that everyone has touched on: diabetes, heart disease, hypertension. And we feel we're working, a lot of people are in these in spaces. One question is how we can have more of a standard clearinghouse so everybody understands where different groups are. And so I just wanted to let people know we're out there. We're working on the movement space, focused on arthritis, which disproportionately impacts women, African Americans, and Hispanics. And this lack of movement and development of arthritis then leads to obesity, hypertension, diabetes, depression. I mean, movement is life, so we could all get up and move, and you'll feel better after you take a little break. And thank you for the ability to share that with you. And I applaud all the speakers. I really enjoyed this session. Thank you very much.
I just wanted to thank the last few speakers because for those of us who are members of the commission, Elena, Omar that works, and Chris, and others that are here, I think we heard what you said. And perhaps we do need to think about a way of involving patients, people, consumers earlier on, and we ought to take that into consideration. Yeah. So I appreciate your comments. We heard it, and we will see how to act on that. So I thank you for that.
Thank you for your time.